Great. Good afternoon, colleagues, and welcome to the noon meeting for the 25th of February. Just by way of introduction, I see we have a full house, up to 22 people in the meeting. I am John Ataguba. You could see my name there. I'm the director of the Health Economics Unit at the School of Public Health and Family Medicine. My research area is areas touch on many things, but primarily looking at health financing, health inequality, and health equity. And to kind of put all together is under the umbrella of the social determinants of health. I also do a bit of research into the economics of addiction, particularly looking at alcohol. But today I will be presenting a paper on financial protection in health, particularly trying to look at how politicians may be able to manipulate their results to suit their purpose. I will try to take it as easy as possible, especially because it might contain a bit of some technical content, but I would try my best to explain. What about financial protection? When we talk about financial protection, it's very easy for people to look at financial protection, especially in the context of health, as trying to protect the money we have, whether in a bank account or you keep at home or stuff like that. But it's broader than that. We'll take a look at that as we move along. In the context of policy making within the health financing space, we know politicians have a very strong influence. And when politicians talk, they usually make promises. And whether they keep the promise or not is another thing to keep in mind. And sometimes you may argue that it's better to have whatever the promise is, that empty promises can be better than no promises if you come in from a side where you think such promises are never ever kept. So it's better not to raise people's expectations than to raise people's expectations. Great. What were you saying about Newton? Can you mute your mics if you're not speaking, please? Thanks. Universal health coverage is usually something that we all talk about in the health sphere. It's very much debated, and it's about providing access to quality services and financial protection. That's basically what universal health coverage is about: providing access to quality health services and financial protection to the entire population. Not just a selected few. And these two dimensions are critical dimensions for assessing universal health coverage. The third dimension, which the WHO will talk about, is a population dimension. And as I've argued in several forums, it's basically kind of nested in these two broad dimensions of access to quality health services and financial protection. What, therefore, is this financial protection I've been talking about? Is it about keeping your money in the bank, making sure that no one attacks it, or what is it? Before I go in there, I would give just a little joke. Perhaps you would try and understand whether it fits within the context of financial protection. If you're not speaking, please mute. I get echoes here and there. Good, thank you. There is it's a very short joke. There is this guy who was walking along the streets, and there is an ATM machine standing beside him. And what he did was he looked at the ATM machine. The queue was so long, and he wondered and thought to himself, what's happening? I've got my money in this bank, and the queue is so long. It means something is happening here. They're trying to withdraw my money. So this poor guy also joined the queue, withdrew his money, and went back into the banking hall, and then told the cashier, "You know what? I'm suspecting something here. My money is not I'm not financially protected by this bank. So I'm taking my money from the ATM. Please don't keep it in the ATM. Just lodge it into the bank." And that's the end of the joke. So in context of financial protection is beyond that. In the health sphere, we want to ensure that when people use health services or when the need to use health services arises, such households are not in any way burdened by that need to use health services. In other words, we say when people finance health services, that payment for health services should not in any way stop them from buying basic necessities like food, shelter, putting children to school, buying clothes or shoes, or having a house, a good, decent house to live in. And once you lack financial protection, it means that you financed health services, and as a result, you became either poor or you're unable to buy food, you're unable to shelter yourself, you're unable to buy the basic necessities of life. And that is exactly what we don't want to happen when you finance health services. How do we assess this so-called financial protection in health? The literature for assessing financial protection in health will tell you you can assess financial protection by looking at two things. One is what they call financial catastrophe, and then the other one is called impoverishment. Financial catastrophe is basically about ensuring that by the time you pay for health services, that amount is not a substantial amount compared to your income. I'll give a quick example as we move along. An impoverishment is a simple one. If you decide to pay for health services, you should not become poor because you need to use health services. Once paying for health services makes you poor, then you're not financially protected. Unfortunately, the SDG negotiations that happened, we put in a lot of indicators in the SDGs. And through consultations, some of these indicators were dropped, especially for assessing universal health coverage, which is one of the goals within the SDGs. It's one of the SDG points that need to be addressed out of the 17 goals. But of course, it fits within goal 3, which is about health. And as a result, indicators for financial catastrophe were included within the SDGs, but the impoverishment indicators were not explicitly included. And there's a reason behind that. It's because the overarching goal of the SDGs is to reduce poverty as much as possible in all its dimensions. So implicitly, one of the dimensions of poverty is health. So it is implicitly within the SDG, but not explicitly. So it's important to keep that in mind. I talked about financial catastrophe as making sure that the amount you spend on health as a share of how much you have as income or expenditure should not exceed a certain threshold. For example, we don't want a household to spend more than 10% of its income out of pocket on health services. If a household does that, that household is said to be incurring financial catastrophe. Sometimes we may use non-food expenditure just to be able to accommodate the fact that poor households spend a lot on food. And as a result, you need to be able to capture whether they incur financial catastrophe or not, which you will not be able to capture if you're looking at total expenditure because they spend a lot on food. So they will never spend a certain percentage on health because more than 80 or 90% has been spent on food, for example. So we may at some point assess financial catastrophe using non-food expenditure. Now, this is, by the way, now let's go into impoverishment, which is the area that this particular paper focuses. Impoverishment from paying out of pocket for health services arises when you look at an individual who is not poor, but because the individual had to use health services, becomes poor. Then we say you have been impoverished by using health services because you paid out of pocket. It's a very simple one to understand. An individual who is not poor but becomes poor primarily because he or she used health services is a problem. We don't want an individual to become impoverished by using health services. And how do we compute that? Within a country, we know what we call poverty headcount, or the percentage of people in a country that can be categorized as being poor, i.e., they live below the poverty line. Now, we also can compute, again, the poverty headcount or the proportion of people who become poor after using health services because they paid out of pocket. So the difference between these two proportions is what we use to define who incurs financial catastrophe, who is impoverished or not. So the difference between the poverty headcount before you pay out of pocket and the poverty headcount after you paid out of pocket is an indication of impoverishment from out-of-pocket spending. So it's a very simple, anybody can compute this. It's very simple. You don't need an economist to do this. All you need is just your ability to count the number of people who are poor and then count the number of people who become poor as a result of out-of-pocket payments. So why then am I worried that politicians can kind of manipulate the results? The reason why I'm very worried is because it's possible that when you choose poverty lines, the choice of poverty line in themselves has an implicit ability to create an incentive that is not needed. And that's what I'm trying to prove here. To be able to see whether if you choose a poverty line and you compare it with the choice of another poverty line, what happens to impoverishment? You'll be able to basically assess whether the choice of poverty line is a problem or not. Poverty lines are very, very important in the poverty literature. Reason being that for you to be able to assess whether someone is poor or not, you need a basis. You need something to judge, and that's where poverty lines come. There are many ways to compute a poverty line, but I'm not going, that's out of scope here. So let's imagine we're able to choose a poverty line. That choice of poverty line, does it really in itself allow you to say that impoverishment is increasing or reducing? It's something that we need to keep in mind. And that can be whether within country, between regions in a country, between countries, or even over time to compare whether the country is performing better over time. So should this matter for health financing policy, and why? We're going to see that in a while. It matters a lot for health financing policy in countries, between countries, and also how politicians can use that as a win-win for them, depending on how they deal with this. The issue, people would argue, again, why are we worried when there is already an international poverty line defined for all countries? For example, the World Bank puts out what they call the international poverty line, depending on whether it's a rich country or a poor country or a middle-income country. And many countries, unfortunately, South Africa is not included, have what they call national poverty lines. South Africa has been struggling over the years to come up with a national poverty line, but there is no national poverty line. But there are poverty lines that have been used in the country, but not an official national poverty line. So you argue, if these poverty lines exist, why are we not just going to use them and forget about this exercise? We'll get to see that in a while. And that means making an argument that the choice of poverty line really matters. When you look at, like I said, regions in a country, you look at between countries or a country over time. They really matter. Now, this conceptual framework is a very simple one. It might be a little bit, it looks intimidating, but it's not. It's a very simple one to understand. But I know, given that it's difficult to kind of explain that virtually, Just take a look at the box to your right that has delta H something there. That box gives you an indication of how you're able to compute impoverishment headcount. Impoverishment headcount is basically, like I said, poverty estimate after healthcare payments minus poverty estimate before healthcare payments. So that's the difference you're seeing there. After healthcare payments is, for example, D2, D3, D4, D5. Before healthcare payments is D1, D2, D3, D4. So that difference between the poverty headcount after you've paid for healthcare and poverty headcount before you pay for healthcare is an indication of how much paying for health services has impoverished households or individuals. Let's take a simple example. If in a country poverty headcount is 30%, that means 30% of people in a country can be categorized as poor. And by the time you take into account payment for health services, poverty headcount increases to 32. It now means that paying for health services made 2% of the population in that country poor. As simple as that. So this graph shows conceptually the issue at hand. And it's in statistics or even economics, we talk about monotonicity. Monotonicity is basically same in English, how something increases and you can see the order has meaning. But in this case, there is no monotonicity in the sense that as you increase the poverty line, you could have a higher impoverishment or a lower impoverishment. There is no order. And as a result, it is problematic. If you look at poverty estimates are monotonous to the choice of poverty line. That is, if you increase the poverty line, the response in terms of poverty headcount is kind of monotonous. If poverty line is basically very high, almost everyone will become poor. And as you reduce the poverty line, the number of people that will be impoverished would continue to reduce. But it's not the case here in terms of assessing out-of-pocket payments. That's basically what this paper is trying to deal with. Great. Again, I won't bore you with this. I'll skip it. Again, what we call dominance. Dominance is a statistical test that we use in economics, same as statisticians do, to assess whether one distribution, strictly speaking, it's either better or lies on top or is ahead of another distribution. So the issue, therefore, issues, many of them, one is that within countries, the choice of poverty line matters when you rank households by impoverishment level. So it's possible that when you choose a different poverty line, you get a different poverty estimate. You choose a higher one, you even get a zero. Very possible. You get a zero, and that's problematic in itself. And the choice of poverty line, again, matters when you compare or rank impoverishment levels by mutually exclusive groups. Mutually exclusive groups can be, for example, male-headed households, female-headed households, or queer-headed households, male-headed households, female. You can have groups that are kind of mutually exclusive, or it could be urban households, rural households, for example, as mutually exclusive groups. You either belong to one or the other, but you're not in all at once. And that's also the issue is that politicians can pick and choose. So they can pick and choose financial protection results that they can accept and report. I can accept this because it looks good at that poverty line. No, I wouldn't accept this. I can accept that. So the picking and choosing is where the problem comes. A politician can demonstrate clearly that they have made progress just by choosing one poverty line that is very, very close, as close to the previous poverty line. They can demonstrate that they've made tremendous progress, when in fact it may not be the case. And that's something that sits at the heart of this paper. So what I tried to do was to come back home to my dear Nigeria to apply the kind of thinking I have to a data set from Nigeria. Of course, you know, Nigeria is one of the countries, the most populous sub-Saharan African country, and it's a country with high poverty rates. and one of, again, one of the most developed countries within sub-Saharan Africa. So it's we normally call it poverty in abundance, which is an irony. So I used here the 2008 NLSS, which is one of the surveys conducted, which is similar, has a base of the World Bank's General House, the Living Standard surveys. It's a national representative survey, and I used very basic variables like per capita out-of-pocket spending, per capita household expenditure consumption. And I try to vary my poverty lines from $1.9 a day to $3.1 a day using what we call the 2011 PPP. PPP here is for non-economists. It's not public-private partnership, but what we call the purchasing power parity. Purchasing power parity is different from the usual exchange rate we see if you go on oando.com. The purchasing power parity exchange rate is a more ideal exchange rate for us to compare countries. Unfortunately, it's not widely used, but when economists want to compare two countries, we defer to the PPP, which is a purchasing power parity. It allows us to take into account the fact that, for example, a bottle of Coca-Cola in Nigeria it can be bought at a certain amount in Canada, in Ghana, in Switzerland. So we basically take a look at how a bottle of Coca-Cola can be bought in these countries I just mentioned, and to compare in terms of exchange rate of $1 to 1 naira or to 1 yen or to 1 cedi, for example, as opposed to the nominal exchange rate we see on Oando. Reason being, again, that if you go you take $1 in Nigeria, whatever they convert it into a naira, and you take that money, you go again to Ghana, you convert it to cedi, you will not buy the same thing. So $1 in Nigeria will not buy you the same in South Africa, same in Ghana or in Malawi, for example. So PPP allows us to do away with that. So whatever you find in PPP, $1 in Ghana is the same as $1 in Cameroon. So the empirical assessment gave me these results. So like I said, we varied the poverty line from 1.9 to about 3 point something. You would notice here on the on this axis the percentage of individuals that are impoverished by out-of-pocket spending, and that percentage is the new is the proportion of people who become new, the new one proportion, as opposed to the previous poverty head count. The previous poverty head count is there. Added on top of the previous head count, what proportion of the population became poor by paying out of pocket. Now you will see how this is varying by choice of poverty line. It's not monotonous. At some point it increases, it decreases, it increases again, decreases, increases. So it means that a policymaker can decide to say, you know what, I'm choosing poverty line of $2.2 a day. And as a result, out-of-pocket payment is impoverishing about 220,000 Nigerians. As opposed to choosing a poverty line of 2.1 that impoverishes 400,000, almost double the number of people who became impoverished. And you could even go as high as possible if you go to another poverty line of 1.9, which is usually the poverty line recommended by the World Bank for low-income countries. Again, at a very close poverty line of 2.3, you could have 330 Nigerians being impoverished by out-of-pocket payment. And it goes on and on. You see it increases, decreases, increases, decreases. It basically means that a politician can sit back and choose whichever poverty line aligns with what he or she wants to pass, a message he or she wants to pass, that I've been successful in providing financial protection because 220,000 people were impoverished, as opposed to what you could see as 400,000, for example. Then I try to see what happens between urban rural location. The zero line is basically says it's equality between urban and rural. In this case, it's not very informative, but here in terms of geopolitical zones in Nigeria, which is a very, very important variable for policymaking in the country for many things, whether you come from the south, the west, the east, north, it really matters. You could see how a politician can demonstrate that in the southwest, we've done better than the southeast, And the Southeast politicians could say, well, if I choose a different poverty line, I have done better than the other guys from the Southwest. So there can be this tussle between the Southeast and Southwest in this case, in terms of who's done better than the other. Again, it's a big political issue that you could use. Again, this is the Northwest versus Northeast, similar scenario. Although in some cases here, in this example, they are not statistically significant. But the mere fact that this could happen, politicians don't look at the statistical significance. They're particular only about the proportions. And these proportions demonstrate clearly that the Northwest is doing better than Northeast at some point. And the flip side is the case. Which do we settle with? Do we use a 2.0 poverty line or 2.5 or 1.9? Now the results are going to be different for the choice of whatever poverty line we have taken. So just to wrap up, it's a very simple exercise, but with very powerful findings. Financial protection has gained prominence. We've known that internationally, even within researchers and policymakers, even in terms of the support I provide to many African countries. We try as much as possible to look at how financial protection has changed over time. And that's where the concept for this paper came about. Working closely with a few African countries brought this to light, that politicians are now able to kind of pick and choose and present the results they want for people to see. So the choice of poverty line really, really matters when we assess the implication of paying out of pocket for health services. And that can happen, like I say, between countries, within a country, between geopolitical zones, between mutually exclusive groups over time, and whatever the relevant comparisons may be within a country. So an improvement in financial protection may be demonstrated at one point, but not at another, or between two zones. We can show that one zone is doing better than the other at one poverty line, and the flip side is the case, then another poverty line, which shouldn't be the case. Then it opens up the whole process to manipulation. And as such, politicians and policymakers will exploit that to demonstrate, like I've shown, success, just by choosing the results that kind of align with what they want to pass, the message they want to pass. Remember the promises we started with? They want to keep, if they want to keep their promises, can show you how much they have done by starting out at a certain year, choosing results that give a very high poverty head count, and then ending off with the year that gives, choosing the poverty line that shows that they've done really, really well in reducing impoverishment levels, which is, again, problematic. So as countries begin to prepare towards universal health coverage, there is a great need to, as much as possible, try to understand the implications of choosing different poverty lines for how you order impoverishment levels and indicators. And it's a very important part of UHC because it is one of the dimensions for us to assess universal health coverage globally, not just restricted to one country or Africa or Europe or Asia, but globally, how we assess impoverishment. And this has kind of featured again, not just within Africa, but even in Europe, where the results from this particular paper have brought to light things that need to be understood and how we can refine estimates for financial protection, especially impoverishment, to be able to douse the kind of variability that we observe here. And also to add, the paper is out. If you really want to take a look, dive deeply into the paper more than I thought I have done. It's a little bit technical, especially for the audience and economics journal. So you just have to kind of wear a little bit of economics hat to sail through the paper. But I think it will be an easy read for you to understand if you're interested in knowing more about that research. And with that, I want to thank you for your time, and note that there's something we're still trying to fight, and we are hitting that as much as possible, and we should all still continue to contribute to hitting that to make sure we quell it and fizzles away forever. Thank you. Great. I'm happy to welcome questions. I see that we can try. Bruce, you can raise your hand, and I'll let you in. Okay, I see there is Veloshni on the line there. Veloshni, please go.
Thanks, John. That was a great presentation. What an interesting topic. Can you hear me?
Yes, I can hear you.
Oh, good. Okay. I mean, it's such a relevant topic, I think, particularly around UHC. I'm wondering if there's any policymakers in the discussion, because they cannot cast in a very positive light. It has been quite kind of wily and manipulative. But aside from that, I think, I mean, the question you're also raising is, you know, linking obviously the poverty lines, but there's also the bigger question around measurement, rather performance of the health system and performance of health policies, specifically targeting universal health coverage and health financing policies. And I think I'm wondering, you know, if we have to kind of think ahead, is how does one address this kind of challenge? Because it is inevitable that decision makers will try and manipulate results in a way that, you know, either casts them, obviously would cast them in a more positive light. So it's not new. I mean, we're living in the age of disinformation, and it's not surprising that would extend to UHC as well, particularly because it's so much under the radar. And I'm wondering what mechanisms exist for how we can, you know, make these processes, one, more transparent, more inclusive. Even, you know, so the discussion now around the choice of poverty line, where you can have potentially, you know, more active engagement from civil society or academics that kind of lays bare that, you know, there's under different scenarios, the poverty gaps and the debt burden is going to look quite different. So, you know, how can this be kind of potentially mitigated? Thanks, John. That was a great presentation. I'll stop there.
Thank you very much, Veloshni. Maybe I can respond to that before Mtiki comes in. Very, very interesting in terms of bringing in politicians into policymakers and politicians as well, possible into the room to discuss this. I've not made any kind of presentation like due to maybe the COVID pandemic as well, has made things kind of difficult in terms of how one can proceed with some of these. But the initial reaction I got also from your colleagues at WHO, including WHO, the Europe region, and HQ headquarters, and of course Afro, is that this is something that we need to put on top of our agenda. There are suggestions that have been made. I think it was even channeled by the WHO Euro region regarding this, was to use the method that they kind of came up with in terms of including people who already live below the poverty line, who make any out-of-pocket payments. Because currently the way these methods are designed, you ignore people who are already poor but pay anything out of pocket. So they are missing. We call them a missing poor in this case. So what they suggested is to include that in the computation of the proportion of people who are impoverished. And the beauty of that is that it reduces the variability. We were able to show that by the time you include that, it reduces the variability in terms of how you choose poverty lines. Now, once that can be done, then we can now settle back and use any of the internationally agreed poverty lines or the national poverty line and make countries report impoverishment estimates using any of these fixed poverty lines, if we're able to reduce the variability that I showed, that variability is a lot. And you could see variability of up to 0.2%. It's a lot if you move it into the entire population. Example, Nigeria with about 150 million, 180 million people. It's a lot in terms of numbers. Then you talked about poverty gaps and poverty burden. In this presentation and also in the paper, because I wanted to be brief, I didn't delve into severity of poverty or poverty gap, but the same analogy applies. That the gap can be manipulated again by looking at the choice of poverty line. It's really something that became an eye-opener for me the moment I saw that. And like I said, it came out of support that I was giving to countries. And I said, oh, so it is possible that this can happen. But of course, they didn't know that happened. But I only knew it happened because I was trying to interrogate data to provide answers to certain questions. And it's something that I think should be on top of policy agenda, and we can bring politicians and policymakers into the room to find a way out. Thanks. So, Ntiki, I see your hand is up. Please go.
Thanks, John. Thank you for a lovely presentation. So I'm not an economist, so I don't speak your language, but I am curious about a reference that you made earlier on around the livelihoods of people from rural areas who tend to spend more on food. And I just wanted you to comment on that, because what we often observe is that the expenditure on food correlates with the expenditure on health. And there's a saying that we often refer to where patients will say they don't even have Panado, which means that even though they have already spent money to access a facility, they did not get even a basic service that they were expecting. And so when you're looking at that, then, if somebody had to pay for transport, miss work, not attend to the fields and all of that areas and other aspects that allow them to generate an income, would this discussion be one that is relevant when you're talking about the financial protection in health and the extent to which people are manipulated in understanding that they have been provided with a service wherein we know that that is not the case in reality. And then following up on that, I also wanted you to just engage us on what might happen in this context, because we are approaching the local government elections, and we know that there is going to be the manipulation. However, with what has been the experience last year with COVID, I wonder what kind of manipulation can we expect from our politicians?
Oh my goodness. Your last question is a really tough one. It's a really tough one, but I'll try. Siki. Let me start with the first one. You touched something very, very important. We as economists, we usually look at what we call discretionary spending, non-discretionary spending. Same in regular parlance. When we say spending is discretionary, it means you have the liberty to choose whether or not to spend on that item. An example of discretionary spending is maybe buying chocolates. Okay, well, apart from addicts. So buying chocolates, you can decide not to buy chocolate and you'll be fine. You're not going to die, okay, if you don't eat chocolate in a month or a year or forever. So in that case, we could say that spending is discretionary. You have discretion to spend or not. Then there is also non-discretionary spending, which food and health come into that pot. And that's why, like you say, there is some kind of correlation between the two. You cannot see a child being sick and you just ignore it, okay? You have to figure out how to get that child back to health, or yourself or a spouse or a family member. There is that urgency in trying to get that person back to good health. And that's where the non-discretionary component comes in when it comes to health spending. Same with food. Of course, you might starve, but you would find a way. It's usually the first thing you want to spend your money on if you have money. Well, if you're rational, okay? The first thing you want to spend, I'm assuming rationality in many of these things. The first thing you want to do is you spend on food. You have to be eat first before you even think of buying a pair of shoes or something. So now these two are very similar. Now, when you come to why you find a lot of poor people spending more on food, it's very basic, and the intuition is very high. Now, when I talk about this, I'm talking of the average. I'm not saying all poor people. Economists are very notorious. We usually use averages. That on average, everything being equal, we expect that the proportion of income that a poor household will spend on food will be greater than the proportion of income that a rich person spends on food. And it's all known. You can easily prove that yourself. Reason being that a poor household in South Africa, for example, might have 100 Rand a month, okay? Oh, sorry, a week, 100 Rand a week. I tell you, that household, the proportion of money the household will spend on food will be maybe about 80 Rand on food, and that's already 80%. But a rich household might earn 50,000 Rand a week. A very rich household can earn 50,000 Rand a week, but it's very unlikely that a household will spend 80% of that money on food. It's very, very unlikely. I mean, no matter the kind of places you go to eat, it's very unlikely that you spend on average 80% of that amount on food in a week. Okay, so now keeping that in mind, we now know that by the time poor households spend a large proportion of their income on food, what they have left is maybe 10%, maybe 6% of their income. But to be able to assess financial catastrophe, we want to see households that have spent more than 10%. Then it means that poor households will never be incurring financial catastrophe because they have less than 10% to spend on health anyway. Though they are going to spend on health, they will. But the amount they're going to spend on health cannot be that large to make them incur financial catastrophe. And that's the reason why sometimes we use the non-food expenditure. I didn't delve much into that because it's another measure of financial protection. I've done a couple of work on that, but what I'm presenting here is on one of them, which is the impoverishment aspect. There is another big issue which you raised, coping strategies. Poor households adopt coping strategies to deal with the cost of healthcare, these strategies are not included in these measures I've just given. For example, some households can decide to sell goats, sheep, chicken, anything they have, or even sell a household item, a television, a car, or whatever, to be able to finance the health services of someone who is sick. Reason being that it is non-discretionary to a large extent. You don't want to postpone seeking healthcare till next year, especially if it's something very urgent. So you would want to seek money wherever you can get them to money to finance the health service. So therefore, households adopt different coping strategies. And these coping strategies in themselves can even impoverish households further. And we try to capture these two aspects. You assess financial catastrophe, you also assess impoverishment, and also look at coping strategies that households may have used to mitigate spending in such a way that you're looking at the sale of assets and they use it to finance health services, and as a result, you don't capture them as being poor. But the reason why they're not poor is because they had to sell an asset. So these are things, many of these indicators are usually included. Now, your last question, Tiki, about advice for politicians, especially how they can, the kind of advice we can give them in terms of how they can, to avoid them from manipulating the results. I think I'm not an expert in politics or an expert in policy making and stuff like that. But the extent I know, it's possible that as researchers, we have the obligation to provide evidence and to persuade. That power of persuasion is very useful, and as much as possible to use prominent figures who are respected by politicians. Politicians respect prominent figures in academia. So when such prominent figures speak about the ills of doing a couple of things, they think about it. So these are the kind of strategies that we can adopt as researchers to have a community of researchers and use different members to achieve different goals. And one way is, like I talked, power persuasion, using prominent researchers can really help a lot. Some people put some questions in the chat box, which I'm trying to read. Monica asks, how will politicians use poverty lines to campaign for equitable distribution of COVID vaccines? Now, we're moving into COVID. Now, let me try and interpret that. What you're trying to say is perhaps it could be that when they want to roll out COVID vaccines, they want to say, well, let's deal with people who live below the poverty line and roll them out. But that is usually not the case when we talk about access to health services. Access to health services usually is determined by need. So if you notice within the country, there's profiling in terms of who are those that are most likely to need COVID vaccines at the moment and who can be put at the bottom of the list. And that is how the distribution of COVID vaccines, if you want to follow the equity rules, should go by. And it's a welcome development. It will be wrong to, even though we know there's a correlation between being poor and being prone to sickness, to quickly start out by looking at poverty without keeping in mind frontline workers who are kind of faced with COVID on a daily basis. So that kind of profiling is very important. But the beauty of this, again, is that policymakers don't, when we compute poverty headcounts, we don't name who is poor and who is not poor. What policymakers use is what they call indicators. They have proxies. They have, for example, we could say people who are poor are people who live in a certain area, people who live in that particular area. So it's some kind of correlates that we use. The reason why we compute indicators is to know the exact number. But for policy, we don't go out looking for John, because John appeared on my list as being poor. Let me figure out where John is, and I target my intervention to at John. No, we have correlates of people who are poor, perhaps people with 5 children, people who live in rural areas, people who have a farm, people. Now, when we have this, we're not saying that all people who live in rural areas are poor or all people who live on a farm are poor, but it kind of gives us an indication of where poverty can be housed, or if I might use that term. I don't know whether I answered your question. Then Veloshni added that coping strategies, including diverting expenditure on other household needs, may include disrupting education of children. Yes. Many families sometimes pull out kids. If you really want to know about this, the World Bank put together what they call Voices of the Poor. And in that document, it's a very powerful document that sometimes when I read it, I want to cry. Because there's a case of a mother saying she held her baby, was basically singing lullaby to the baby until the baby died. Why? Because she couldn't afford to seek healthcare. That really touched me. It was like, you see, you have an ability to do something which you thought you could, but you just can't. You're holding your baby until your baby dies. And it's very emotional for a mother to see that happen. So it's a very, very serious case. It looks very trivial, but it's very serious. Poverty is real in all its dimensions. I also see here, I think that's pretty much it. Veloshni says she's going to leave. I think she must have left. I also see a couple of people with hands up. Herbert, please go. Herbert, your hand is up.
Oh, sorry, I'd forgotten to unmute. Thanks, Prof. That was a splendid exposition of catastrophic expenses. I'm just worrying about the rural context, where earnings and income are stored in the form of livestock and other agricultural produce. Well, in that one approach where households are asked if they had sold off assets to cope with healthcare expenditure, I think that would be captured, because they would say, I sold a goat or a sheep or whatever. But when it comes to calculating impoverishment, catastrophe and impoverishment, I'm wondering whether these methods are common, where families use assets as stricken goats and want to pay for health services. And we know that in some rural communities in the African context, people do get health care from faith healers and traditional healers. The debates on that aside, still those are payments, or they even sell these assets to pay for transport to access formal healthcare services. I'm just wondering about that.
Thank you very much, Herbert. Very good observations. I think I kind of touched on some of them while I was rambling here and there. Yes, unfortunately, like I said, the indicators that I introduced you to these indicators don't capture aspects of selling assets and stuff like that. There are other complementary indicators, like you also alluded to, in terms of the proportion of household assets and how much, how many assets, or how much were the assets worth, etc. These indicators are complementary indicators. We usually have a dashboard to show the different aspects. One thing that I also need to add is that it is possible that in a country we have zero impoverishment or zero financial catastrophe. It's not all good news. It's not all good news. It could arise primarily because no one was able to even pay for health services, and as a result, there was no payment. And because there was no payment, zero all recorded. And the case of the woman holding her baby is pretty much happening a lot in that country. Because that woman, it will be recorded that she had zero out-of-pocket payments, and as such, she wasn't impoverished. But what she went through is the height of impoverishment or height of anything you can think about, because you don't have money. You're not financially protected. She wasn't financially protected. So I agree. All these indicators have to be looked at pari passu, that's together, and rather than one versus the other. If that helps. Good. There's no other person raising hands. No question in the chat box. Great. So I think we are kind of done. I hope so. Great. I want to then thank everyone for coming to the noon meeting, and at least for listening to my talk. Whether it makes sense or not, I'm glad you were there to listen. We hope that we'll keep this fight alive and to see how we can achieve universal coverage, which is a big dream that not just a dream, we want to bring it to reality. So on behalf of the director and head of the Department of Public Health and Family Medicine, Professor Nando Meyer, I think I will officially bring this to a close, and thank you all for joining in. Have a nice day further. Bye-bye.